So let's leave our drugs that worked on sympathetic activity behind. And now let's look at the direct-acting vasodilating drug, the drugs that have nothing to do with the ANS. Well, these are small sections, each worth several points generally for board question. First, we're going to work with drugs that interfere with nitric oxide, with NO. And there are two drugs in that small section, hydralazine and nitroprusside. Both are prodrugs. Prodrugs meaning they require metabolism in order to release that nitric oxide and then decrease total peripheral resistance through arteriolar dilation. Hydralazine is primarily metabolized in the actual arteriolar tissue. So as such, it is known as a selective arteriolar dilator. Understand by this is not a drug that will also dilate veins, only dilate arterioles. Because of the relevance of arterioles and resistance, this is a drug that could be used even in severe hypertension cases. Hydralazine is a drug that has been well established right from the start for its role in SLE-like syndrome in slow acetylators. Just like the drug procainamide, just like the drug isoniazid. So this time around, I would like you to work it in reverse than what we've done before. If you have a drug here that causes SLE-like syndrome, what do you think it means of its protein binding? So I can just about hear you say it has high protein binding. Particularly, if it has high protein binding, it means it has little free fraction. So make the jump. With methyl dopa, we had a drug that had high protein binding that would be used in pregnancy, but had immune dyscrasias. Here you have a drug that has immune dyscrasia. My question to you is, do you think you could use it in the pregnant woman? Of course, the answer is yes. This is a drug that is also used in pregnancy and the management of hypertension. So that now you have on your hand two drugs for hypertension in the pregnant lady. Alpha-methyl dopa, which is good for mild to moderate hypertension, and hydralazine, which would be more amenable of the management of moderate to severe hypertension. Well, once you know this, you're set. This is all we want you to know about hydralazine, because the edema is the classic hypoperfusion of a kidney. While you lower blood pressure, renin comes out. And certainly because we no longer interfere with sympathetic activity, you do expect reflex tachycardia. This is why hydralazine should always be used in conjunction with possibly diuretics for the edema. And obviously for the reflex tachycardia, the use of beta-1 blockade and beta blockers in general should be co-administered. Nitroprusside, you see, unlike hydralazine, in its name it has nitro, telling you it is a prodrug of nitric oxide. And that nitric oxide, unlike that of hydralazine, will be produced both in arterioles, decreasing TPR, having a strong vasodilatory and hypotensive effect, and also in veins. As such, it dilates any vessel compartment in the body. Well, it makes it the drug of choice used IV in hospitals for hypertensive emergencies. Nitroprusside, though, has a big problem. The other half of the molecule, if you want, is the prusside portion. And the prusside portion of the molecule is the one responsible for cyanide toxicity. Because of this cyanide toxicity, you cannot use nitroprusside for much more than 24 to 36 hours at a time. Beyond that, you would run the risk of losing the patient to cyanide poisoning. Cyanide poisoning is managed by the co-administration of first nitrites and then thiosulfate. Nitrites, if you look in the margin of your syllabus, are used in order to get methemoglobin. Methemoglobin, which is really hemoglobin with ferric iron in the middle of it, has less affinity for oxygen. And if it has less affinity for oxygen, for one, it can allow the release of oxygen into those tissues that are suffering hypoxemia right now. But also at the same time, it will allow cyanide to have more binding sites on the methemoglobin. In effect, methemoglobinemia will serve as a carrier of cyanide. The main reason you want your cyanide to hop on this methemoglobin is because while cyanide is on methemoglobin, it is not blocking complex 4 of electron transport chain. If it was to block complex 4 of electron transport chain, it would be untouchable by us with antidote. It would run down the ATP stores of cells in your patient's body and result in cell death. At all costs, we want to avoid cyanides binding to cytochrome oxidase of electron transport chain. For this reason, nitrites are first administered to cause methemoglobinemia. The co-administration of thiosulfate or subsequent administration of thiosulfate is to try and grab some of the cyanide as a thiocyanate. And the thiocyanate is less toxic, less permeable to the cell to get to the electron transport chain, and in a way easier to eliminate from the body. Nonetheless, never forget, in spite of the actual potential of giving nitrites and thiosulfate, you cannot use nitroprusside for much longer than a day or two, and as such it remains purely a drug of short-term use in hypertensive emergency, just the best one for that matter. Still in the direct-acting vasodilators, let's check out the drugs that act by opening potassium channels. As a matter of fact, the first thing you're going to do in your book is name them properly as ATP-dependent potassium channel. You know, that goes back to me telling you in a chapter of antiarrhythmics, not all potassium channels are the same proteins. They may all pass potassium, but they're all very different targets for drug. An ATP-dependent potassium channel is going to be found in two selective tissues, in the arterioles, but also in the beta cells of your pancreas. In both types of tissue, the fact that you open a potassium channel must result in increased potassium efflux, and with the loss of positive charges in the hyperpolarization of these cells. Well, in the arterioles, hyperpolarization of smooth muscle will result in arteriolar dilation. You are absolutely fine to think that these are actually selective arteriolar dilator, the same way as hydralazine was. In beta cells of the pancreas, hyperpolarization will result in decreased insulin release. So who are the drugs who share that vasodilation effect, so I can use them for high blood pressure, and also that drop in insulin release, meaning they would cause a diabetes that would have been drug-induced here? There are two primary drugs in the US for this, the drug minoxidil and the drug diazoxide. They can actually both be used in severe hypertension, or even in some cases in hypertensive emergencies. They're available IV in hospitals and are very effective. But because of their effect on insulin release, it would simply mean to the drug company that if they were using these drugs, let's say orally for chronic management of high blood pressure, they would end up developing in that patient a drug-induced diabetes. Impossible. So as we use these drugs acutely, there is a need very much for remarketing and reorienting at least one of these drugs. Minoxidil is actually Rogaine. And minoxidil has probably brought more money as a topical treatment for baldness than it ever has as a drug for hypertension. So as such, as I'm looking at the side effect of these medications, it's critical you associate increased hair growth with the drug minoxidil. It has nothing to do with its potassium channel opening effect. As a matter of fact, to tell you the truth, minoxidil is a prodrug that needs the liver to be sulfated in order to work. Obviously, it's not by rubbing it on your hair follicles that it reaches your liver and it gets sulfated. So it is a different pharmacology to understand really the effect on hypertrichosis. I really have no clue how it causes hair growth, and if it was that miraculous, I guess we would not see that many bald people out there either. The other big side effect is certainly the one shared by both drugs, which is to trigger hyperglycemia because of decreased insulin release. Look, for diazoxide, it is such a strong effect that diazoxide has been used for the treatment of insulinoma. You know insulinomas, those pancreatic tumors of beta cells that produce too much insulin and present with severe hypoglycemia. By the way, do you remember in physio how we recognize insulinomas from factitious administration of insulin? Oh, I'm sure you're all singing back to me the issue of the C-peptide, and you're absolutely correct. There would be increased C-peptide as you have an insulinoma, and no such C-peptide increase if it was an insulin administration. Well, the idea is with diazoxide to suppress the insulin release by the tumor. So remember those two. You know, to me, for my boards, it's the same as remembering hydralazine causes SA-like syndrome, or nitroprusside is associated with cyanide toxicity. These are the kind of ham and cheese interaction, if you want, of drugs for board question, where you know the drug, you know a specific effect to tag it to. Because when it comes to edema, that's the renin-angiotensin-aldosterone effect. We need to give diuretics. And when it comes to reflex tachycardia, that's the hypotension causing an increased sympathetic. So you know to also administer beta blockers. Classic direct dilators.